All right, so we'll cover the mechanics of inhalation today. Hopefully, it was a good read as you went through it. I know there's a lot of verbiage in there, and hopefully, we'll make that help that make a little bit more sense as we progress through it. So, the first couple of slides are just going to kind of cover the learning objectives for the entire chapter. So, you'll notice that this lecture is broken up into two different parts. We have a part one and a part two. We'll plan to cover part one today, and then we'll focus on part two. Uh, next week. And then remember, we'll do a little bit of a review for our first upcoming exam in cardiopulmonary MP. So those are our learning objectives. I'll not read those individually, but they're there, and I think there may be another slide as well. Just as we go through, there's a lot of information involved in this particular chapter. So kind of. Uh, So it's good to kind of take it in a couple different days or two different chunks, break it up into two different halves, if you will, so that hopefully the information is a little bit more digestible. Uh, when we talk about mechanics of ventilation and so forth, a couple of things that we're going to want to begin to understand is you do have elastic resistance or elastic forces within the lung. There's also going to be some frictional resistance and so forth. You'll notice that in the graphic depicted here that there's a little bit of tug of war, if you will, a pull in one direction and an opposing pull in the opposite direction. And if you think about the way that the lungs function or how the lungs work, that is essentially kind of what's going on with each and every breath that we have. We do have this little game of tug of war, if you will, between the chest wall and the lungs. Uh, when we and we'll talk about uh, airflow, static conditions, pressure gradients, and this and that. But ultimately, what we want to make sure that we understand from this is the lung tissue itself. So the lungs have a natural tendency to want to recoil inward. So they've got an inward pull or an inward recoil about them, as opposed to where the chest wall has an outward pull to it. So while the lungs pull inward, the chest will pull outward, and that's where we're getting that little bit of a tug of war and why you're seeing that illustration uh, listed here. So if you think of the term elasticity or elastic, that is the ability of an object to be stretched and return back to its original shape. A lot of individuals tend to mix it up that elasticity is stretchability, and to an extent it is, but it is the ability to go back to its original shape. So for instance, if I have an elastic waistband on with my shorts or pants, those are nice that I can pull them out, but nice so that they don't require me to tie drawstrings together or put on a belt because the elastic waistband should conform back to the waist and hold the pants or shorts, whichever it is, in place. So when we talk about the elasticity of the lung and of itself, like we said, it does want to recoil inward, and it does have elastic fibers that are going to help with this. So you've got the elastic fibers of the lung tissue or the lung parenchyma itself. There's also going to be surface tension forces, and of an interest note, those do contribute pretty greatly to the elastic recoil forces. And we've got a section on surface tension. We'll go over that, but ultimately. I know that you guys have talked about this and learned about this a little bit earlier, but we know that surface tension is essentially the force that opposes inflation. And you guys are learning about a significant volume of laws this semester. And when we begin to talk about surface tension, we know that Laplace's law is involved there, that as the radius of a sphere decreases, so as the radius of a sphere decreases, its surface tension will increase. And then we're going to talk about the role that surfactant plays. That the body, it's a substance that the body produces that helps to decrease their surface tension and makes it a little bit easier for the alveoli to be inflated. But but also will play the role, look at the role that surface tension has, and also to facilitate um, surfactant and surface tension, the role that it has to facilitate uh, the ability of that alveolus to deflate or recoil inward again. So we'll cover that once we get there in a little bit more detail with some graphics in the PowerPoint to help kindly express what it is that we're mentioning. When we talk about elastic resistance and frictional resistance, the elastic resistance is going to be under static and dynamic conditions. So it's going to be important for you to understand the difference between a static condition and a dynamic condition. So static, if you think of it, is going to be in the presence of no flow. So when we look at static conditions or when things are still, there's no flow. Dynamic conditions will take into account movement. So we could take into account airway resistance, the flow of gases through the lungs and so forth as we are there. And then we look at the frictional resistance. Those are the forces that are going to expose the expansion of the lungs. So the ability of those lungs to be expanded. And that's going to be, for the most part, under dynamic condition because in order for those lungs to expand, there's going to have to be movement. So I hope that makes pretty good sense intuitively. Ultimately, what we see here, excuse me, in this photo, you'll see that you have the trachea. We've talked about in anatomy that the bifurcation is the carina leads to the right main stem bronchus, the left main stem bronchus. You also see this pink tube that's been illustrated here. That pink tube is the esophagus. So remember, we said that the trachea sits pretty much anterior to the esophagus. That's why we've got those incomplete rings, though, that we had mentioned. So just kind of review some of the information that we went over last week. The esophagus sits in behind that. The incomplete rings around the trachea is going to help facilitate or make it easier to swallow, uh, but also provide rigidity to the trachea. And you'll notice inside of the esophagus we have this white line with this little manometer that's it. So it's an esophageal balloon tipped. It's an esophageal pressure manometer, essentially, is what it is, and that's going to help us to be able to measure uh, pleural pressures. So what we're looking at is we have this airway opening pressure, which is, like we had mentioned before, at sea level or 760 millimeters of mercury. You'll also notice that the pressure, the alveolar pressure, is equivalent to atmospheric pressure. So this would tell me essentially if airway opening pressure and uh, alveolar pressures are equal, then I would have to be either at end inspiration or end exhalation. And in this case, there's if the pressures are equal, there's no gradient, so there's not going to be any kind of flow. But just depicted, we do have the elastic recoil of the chest. Remember, the chest always wants to move outward, so you'll notice that arrow moving in the outward direction. The elastic recoil force of the lung is for the lungs to always want to recoil inward, so you'll notice that inward direction of the uh, lung tissue in of itself. So we'll also notice that we've got these little negative signs in this particular area. So this is your pleural space. Remember, you've got the visceral pleura, which covers the lung, kind of folds back over itself to the parietal pleura, and that potential space between your visceral and parietal pleura is the pleural space. Uh, and that pressure should be subatmospheric. That's going to help um, facilitate ventilation or the movement of air into the chest once we get to that point. So if alveolar pressure is equal to airway opening pressure, then in that point, flow is not going to occur. So if what we're seeing here is the depiction of end inspiration, so I've taken a breath in, uh, the ultimately when the diaphragm contracts, the diaphragm's going to move downward, and that's going to create this negative pressure. As it creates this negative pressure, there's now a pressure gradient. So if we're at sea level, the atmospheric pressure at my airway opening or at the mouth is 760 millimeters of mercury, then when that negative pressure at the beginning of inspiration starts, then what's going to happen is that's going to allow that pressure gradient is going to allow air to move into my lungs. And then at a certain point, the pressures are going to have to equilibrate. An example, airway opening pressure 760, alveolar pressure 7, that they are now equal. And then, so that's going to be at end inspiration. You're done taking your breath in. And now those elastic recoil forces that we talk about, that inward pull of the lungs is going to help to facilitate your passive exhalation process. Remember, we had established last week that inhalation is an active process while exhalation is predominantly a passive process. Can exhalation be active? It absolutely can, but under normal circumstances, inhalation should be active while exhalation is passive. So that's pretty much what's depicted by this screen here. Is just showing the example of the outward pull or the elastic recoil of the chest, that outward pull of the chest to move outward, and the inward recoil of the lungs for that to move inward. So if we back it up a couple of slides or to the original slide where we have this tug of war, that's essentially what's going on between the lung tissue itself and the actual chest wall. So if we look at this concept question here, the pressure in the alveoli just before inhalation begins at zero, and at the end of a 500 milliliter inspiration, just before expiration begins, alveolar pressure is also zero. Explain why alveolar pressure is zero in both instances, even though the lung contains more volume at the end of inspiration. It's the same phenomenon we had just talked about. So you're getting the 500, and which should hopefully be a relatively normal tidal volume. As you're breathing in, those pressure differences have changed. So the pressures had equilibrated. So if you're calling the um, uh, airway open. And I want you to understand that these uh, numbers that they've utilized in your textbook are, aside from the 500 cc or 500 milliliter tidal volume, that is an app. If we're looking at the num the numbers are somewhat arbitrary that they've put. So I don't want you to get hung up on trying to remember the numbers, but just the overall concept is what's really the most important. So there had to be a pressure difference in order for that 500 cc's or 500 milliliters of air to get into the chest on inhalation. So when we inhale, that 500 cc's is going to go inside of the chest. And at a certain point, those pressures are going to have to equilibrate. So alveolar pressure is going to have to be equal to airway opening pressure for flow, the inward flow of that 500 to stop. Now, that answers the question. And then because you're at end inspiration, flow is stopped, the pressures are going to be equivalent to each other. Uh, and now those elastic recoil forces can take over. And then at that point, alveolar pressure is going to become greater, or the pressure inside the chest is going to become greater than the pressure at the mouth, so that that air can passively be moved out of the mouth. So that leads us into our pressure gradients. Flow is not going to occur unless you have a pressure gradient. And a pressure gradient is simply you're going to use subtraction. So you're going to take an area of high pressure and subtract from that an area of low pressure. And in the presence of, or for our case, flow is going to move in a situation in a pattern or an area of high pressure to an area of low pressure. So the pressure gradient is responsible for air flow. And when it says that gas always flows down pressure gradient, that means it's going from an area of high pressure to an area of low pressure. We've experienced this quite a bit. You know, if you've ever been uh, sitting in the house and you may begin to believe that there's some paranormal activity going on if you happen to see a door just kind of push to or what have you. Chances are what has happened is there's been maybe your air conditioning unit or heating unit kicked on and that changed the pressure inside of the room. Well, that pressure's got to escape to, if the pressure built in the room, that pressure's going to escape to an area of lower pressure. It just so happens that pathway out the door is what's going to cause that door to close as that pressure is trying to escape. So that fourth bullet down, or the third bullet under pressure gradient, where it says if the pressure gradient is zero, there's going to be no airflow. And we've got to make sure that we appreciate that. Uh, so at the beginning, uh, if I'm at and I'll hold that till we get to the volume piece of that. But just understand that in order for us to take a breath in, there has to be and spontaneously we breathe off of what we would consider to be a negative pressure system. You're going to get the contraction, the downward movement of the diaphragm. That downward movement of the diaphragm is going to create a negative pressure or a vacuum inside the chest, if you will. Now pressure inside of the chest is less than what's out here at the mouth, or your airway opening pressure or atmospheric pressure, and that will allow air. So diaphragm contracts, the rib cage is going to begin to expand. As it does this, air is going to move into the lungs, but your lungs don't continue to fill and fill and fill and fill. They do eventually stop. Why do they stop? Why do they stop? Because the pressures then equilibrate, and then those elastic recoil forces of the lung begin to take over to facilitate the removal of the air via exhalation. Uh, so uh, when we look at alveolar pressure or your intrapulmonary pressure, so do note as you're going through and reading your book, there's going to be one pressure may have two different names for it. So try not to get too confused when you're looking at that. Alveolar pressure, intrapulmonary pressure, those are pretty much synonymous terms with each other. And that is going to be the overall sum if you're adding the chest wall and those lung recoil pressures together. So the outward pull of the chest wall and that inward pull of the lungs and of itself. So just like we were talking about different pressure gradients or so forth. So you do have your trans-respiratory pressure, your trans-airway pressure. Uh, you have your trans-pulmonary pressure. You've also got trans-thoracic pressure. Remember the prefix trans is across. So trans-respiratory across the respiratory, trans-pulmonary across the lungs, trans-thoracic across the chest. Uh, so those pressures will be important to remember. But I don't want you do need to understand and have an appreciation for the terminology, but don't let the terminology confuse you. Uh, we want to try to simplify it as best we can and how air gets into the lungs, how air comes out of the lungs, the outward pull of the chest wall, the inward pull or the recoil forces of the lung tissue and of itself. But these are terms that you're going to see time and time again as we transition to the summer semester, get into mechanical ventilation. You'll begin to look at like your trans airway pressure, and that'll take on not necessarily a different meaning, but we'll look at that a little bit uh, differently when we're talking about a peak inspiratory pressure and a plateau pressure. I'm not going to go too terribly deep into that right now because we're just learning the basics at this point. Once we get this foundation set, then we can begin to build upon that. Once we transition a little bit closer to the summer and get into mechanical ventilation, and then hopefully by laying the groundwork with the terminology now, it'll make things make a little bit better sense. It seems like a long way away, but we're already in week, what, four of the uh spring semester. It's a 16-week semester. So I mean you guys are just right at three months away from getting into mechanical ventilation and so forth. So that's why it's important for us to get this down now. So our transrespiratory pressure, we had mentioned it is also known as your trans airway pressure. Mathematically, each of these are gonna uh, be be shown here. So your transrespiratory pressure, you can see that that's alveolar pressure, uh, and you're taking away from that the airway opening pressure. Try not to get too caught up in the mathematical formulas that are listed there, but just understand the overall general concept uh, of what the pressure is. So a trans respiratory pressure or a trans airway pressure, this is going to be the gradient that allows for that gas to go in and out of the lung. So if you understand the overall concept of it, then it makes that mathematical equation that's represented there in yellow make a little bit more sense. So we said that in order for gas to flow, there must be a pressure gradient. Well, it's going to go from an area of high pressure to an area of lower pressure. So, and then we know that that pressure is going in and or out of the lungs. So you're going to have your alveolar pressure, the airway opening pressure. So there's going to have to be a difference, whether at a certain point, say upon inhalation or beginning inhalation, that pressure is greater at the mouth, less in the chest. That allows air to go into the chest. At end exhalation, those pressures become, for the most part, equal. And then the elastic recoil forces of the lung take over. That causes the pressure now to be greater than it is at the mouth so that exhalation can occur. So we want to make sure that we understand the overall concepts. Transpulmonary pressure. We said this is the pressure pretty much across the lung, if you will, and that is essentially going to be the pressure that's going to help to distend those alveoli. And the goal of taking a breath in is to move air into the lungs and to get it deep enough into the lungs so that that inspired air can make it down to the alveoli. Remember, we talked briefly last week about uh, dead space and shunt. And we had, and you've got to make sure that you understand that ventilation is the movement of air in and out of the chest. For our purposes, ventilation is going to be the movement of air in and out of the chest. But we also understand that if arbitrarily I say that we have a tidal volume of 500 cc's, that remember and I'm breathing spontaneously, and I take in that 500 cc tidal volume, that not all of that 500 is going to make it down to the alveoli because some of that gas will stay in the conducting airways, the oropharynx, the nasopharynx, so forth. So we get to the effective portion of the breath or the effective ventilation portion, and that is the only gas that gets down to the alveoli. See something in the chat box? Let me take a peek at that right quick. Question. So the first concept question is more about understanding the relationship that pressure plays and less about what the volume is doing, how it's changing as the pressure in the diaphragm decreases. As the pressure in the diaphragm decreases, it rises inside the alveoli during. Let me open that up so I can see it a little bit better. Uh, as the pressure in the diaphragm decreases, it rises the alveoli during expansion, then reaches zero again as the pressure changes, moving down the pressure gradient again. Yes, there's always going to be a pressure. So pretty much what you're saying, Faith, in that is at a certain point during ventilation, is the pressure at the mouth greater than the pressure inside of the chest? Yes, that's going to be what allows for inhalation to occur. Then those pressures equilibrate, and the elastic recoil forces of the lung are going to take over. So now pressure inside of the chest is greater than airway opening pressure or your atmospheric pressure, and then that's going to facilitate the movement of air out of the chest. So yes, the overall generalized concept is what we were talking about there. So the first concept question that we talked about was talking about you taking a breath of 500 cc's and those pressures essentially being equal. That's at the point of no flow. Those elastic recoil forces have not taken over yet. And so essentially we've taken the breath in, and the fact that those pressures are now equal allows the breath to stop. The thing that takes over next, which is not incorporated in the concept question, uh, is what would happen after that equilibration arises. Then those elastic recoil forces are going to take over. Then the pressure inside of the chest becomes greater than the airway, and the gas is now allowed to move out via exhalation. Does that help, Faith? Awesome. Good question. No problem. When we look at transthoracic pressure gradient, again, that's going to be the pressure across the chest wall, if we will. Uh, and this is also going to have another terminology that can be, or more terminology can be. So transthoracic pressure or transmural pressure are pretty much synonymous terms, and that does essentially mean the pressure gradient across the chest wall. Um, and that's important to understand because we do have pressure that can be applied to the chest and so forth. I mean, if we think about it like this, I'm going to say this just hopefully for the purposes of making things a little bit. I know that you guys are taking pathophysiology, and everything that we're talking about right here is under the normal physiology circumstances. So we're not really taking into account disease just yet. This should lay the groundwork to hopefully help those diseases make make better sense. But we do look at and maybe I should save this until we get to compliance, but I'm going to go ahead and mention it briefly. We'll cover it again when we get there. But compliance is the ability essentially of the lungs to receive volume. Uh, with compliance, you do have a chest wall compliance and you have a lung compliance. So the lung tissue itself has to be ready to accept volume or have the ability to accept volume. But the chest wall also has to have the ability to allow those lungs to uh, accept volume. For instance, if you were to have someone that had a chest wall deformity, whether it be kyphoscoliosis or something of that nature, if they're physio or anatomically bent in a certain area, that portion of the chest is not going to be able to expand or to help facilitate receiving volume as much as the unaffected side of the chest. And maybe even a better way to explain that would be uh, now, I know not everybody in here has probably ever played football, but I can remember if I was carrying the ball and I got tackled by three or four individuals, and those four individuals were lying on top of me. In that moment, it was difficult to take a breath because not only did I have my body weight pushing on my chest, but I had additional people's body weight pushing on the chest. So it makes it a little bit that was my lung compliance poor at that point? For all intents and purposes, no. But my chest wall compliance in that moment was compressed, so it made it difficult to be able to take a breath in. So in pathophysiology, you're going to learn about obstructive disorders and restrictive disorders. With obstructive disorders, the lungs tend to be a bit more compliant in that they receive more volume. The issue with obstructive disorders is because of airway, an increase in airway resistance, it becomes difficult to exhale the entire volume out. That's why with a COPD patient, chronic obstructive pulmonary disease, whether that's emphysema or chronic bronchitis, because both of those are a COPD, the air that goes in doesn't get to completely come out before the next breath goes in. So therefore, they're constantly kind of taking a breath in on top of breath that didn't get out. So when you hear terms such as an increase in your AP diameter of the chest wall or that barrel-shaped chest that they take on, so it widens out a little bit because there truly is trapped air that can't get out of the chest wall. So then that's gonna change the overall configuration of the chest. So with an obstructive disorder, air can go in, but air has a tough time getting out. With a restrictive disorder, and before I move on to a restrictive disorder, we may have done this exercise before, but I think it's worth doing again. If you want to kind of know what it's like for a COPD patient to breathe, I would encourage you to take in as big a breath as you can and let just a little bit out. And then try to take another breath in on top and let just a little bit out. And then continue to do that. And you'll feel that now you've got air trapped in your chest. And these individuals are having to breathe like that essentially all of the time. And you can see where during an exacerbation that might really increase their overall work of breathing. So now we'll move to the restrictive disorder aspect of things. With a restrictive disorder, your lungs are not compliant, so they do not receive a lot of volume. And remember, compliance, and we're going to go over compliance here in just a little bit, but compliance essentially is the ability of the lungs to receive volume. If you're highly compliant or you have a lot of compliance, they can receive a lot of volume. If they're poorly compliant or have low compliance, they cannot receive a lot of volume. In obstructive disorders, they're typically going to be on the higher compliant end because they're holding more volume and of itself. Now that doesn't mean breath to breath they can take really large breaths, and we'll go over the normal spirogram, and that'll make sense here in a few slides once we get to that section. Uh, but in restrictive disorder, individuals have low lung compliance, so their lungs do not receive a lot of volume. So these individuals have to really work hard to get air in. Air comes out pretty easily because those high elastic, they have an increase in elastance. So remember the elastic forces allow the lung to recoil inward and do what it wants to do. So individuals with a disease such as like pulmonary fibrosis, it's harder to open that lung up, but because of that increase in elasticity, the lung closes. So harder to breathe in, uh, harder to breathe in than it is to breathe out for those individuals. And probably the best way that we can mimic that of a restrictive lung disorder would be I would encourage you to have someone bigger than you put you in a bear hug, have their arms and squeeze you around the chest, and continue to apply pressure on your chest as you're trying to breathe. And you'll notice you have to work quite a bit harder to get that air in because now your chest wall is kindly being compressed, and it mimics a restrictive disorder. Uh, and that's the easiest way to try to explain the two that I've come up with that makes the most sense. And we'll again touch on that here in just a little bit. But we do need to make sure that we have an appreciation for what these different pressure gradients mean and uh the other names that are such as transmural pressure and transthoracic pressure. Uh, so uh and hopefully you've noticed that when you come to these concept questions in your textbook, if you don't immediately know the answer, the subsequent paragraphs after the concept questions tend to provide you the information needed to answer said question. So when we look at this particular concept question uh, in the textbook, when it says that at the end of a spontaneous 500 milliliter inspiration, the alveolar pressure is zero. And do keep in mind, some of these numbers are utilized like this just to hopefully help math make it a little bit easier. So we'll not get lost in those weeds. But the alveolar pressure is zero at the end of the positive pressure. So notice what's different here in this question. Spontaneous ventilation versus positive pressure ventilation. What's the difference in the two? At this point in time, we've not covered a lot of that, so it might be difficult to have an appreciation for what the difference into spontaneous ventilation or spontaneous inhalation is just how you and I are breathing right now. If we say that there's positive pressure involved, that means that one of a couple of things have happened. We have placed a mask over the patient's face, such as in CPAP or BiPAP, and we'll go over the difference. You don't need to know that continuous positive airway pressure or bilevel positive airway pressure is what BiPAP is, and we'll cover that. That right now is not the time to do that. Or there's an endotracheal tube down someone's throat and they're attached to a mechanical ventilator, and that mechanical ventilator is utilizing a compressor and other internal workings to essentially push air into the lungs. So under spontaneous ventilation, we breathe off of a negative pressure system. The diaphragm contracts, it decreases the pressure inside of the chest. So that helps to move in that 500 cc's of tidal volume. Now, what happens is if you are receiving positive pressure ventilation or a positive pressure breath, the machine is designed to deliver 500 milliliters of pressure. But because it pushed it in as opposed to the ability of a spontaneous breath of your lungs essentially being able to pull that 500 in, but instead it was pushed. That's essentially why the alveolar pressure is greater now with 500, and it's because it was delivered with positive pressure as opposed to the normal spontaneous ventilation phenomenon, how we usually breathe. Uh, Also important to understand too that remember we talked about a week or so ago the thoracic pump mechanism. So when you take a breath, spontaneous ventilation is going to help to facilitate venous return to the heart. Uh, so that's going to uh, be helpful. When you have a positive pressure breath, that positive pressure in the chest can actually impede venous return or slow down venous return to the heart. So that can actually make it you can experience some negative consequences of that too. And I promise those are things that we will go in more detail on when we get to the summer and we start to talk about mechanical ventilation, because there's actually a chapter that talks about the extrapulmonary effects, and then we talk about the hemodynamic effects. Laying the groundwork now, we'll build upon that once we get to the summer semester. But ultimately, the reason you have a difference in that alveolar pressure is because one of these is a positive pressure breath and one is a negative pressure breath or a spontaneous breath. So normal and spontaneous breath is normal breath, how you and I are breathing right now. Positive pressure is where you're taking and using some type of patient interface, whether it's a mask or an endotracheal tube or even a tracheostomy tube, and you're applying positive pressure. The end result is you still take in a 500 milliliter or 500 cc tidal volume. It's just different in how it got there. So now we're going to talk about the act of inhale, and won't be able to do it during this session, but I will record something a little bit later today when I can hopefully go through our party box and stuff and find what I need to do it. But I need to get a balloon, a bottle, and I'll actually build a lung model, and I will go back over some of these things and kind of show you the inflation and deflation of another balloon that I'll put inside of that bottle. So I will create my own chest and lung situation with the diaphragm, and I'll be able to uh, pull that diaphragm down, and you'll be able to see the balloon inside the bottle inflate. Now, it won't be, it won't inflate fully because I'm not able to generate enough pressure to do that just with the diaphragm that I put on it. But I don't have the stuff that I need to make it right now, but I will record a smaller segment of that to go over, and I'll send that out to you as well. So inspiration, those muscles that we talked about last week, the diaphragm, scalenes and stuff, those muscles of ventilation are of inspiration. Diaphragm is going to contract, and that's going to allow, when the diaphragm contracts, the chest wall is going to expand. Chest wall is going to expand, and that's going to give rise to the chest. And now we're going to have a situation where we're going to have a pressure gradient that has been created. Notice our pleural pressure here begins to and so you have alveolar pressure, the pleural pressure. There's now going to be a gradient. That alveolar pressure drops below your airway opening pressure. So airway opening pressure here at sea level, 760 millimeters of mercury, that now when the diaphragm contracts, it drops the pressure inside of the chest. So there's a pressure gradient that's going to allow air to flow into the chest, and then the lungs can feel. Now, remember, the lungs are not going to continue to feel and feel and feel and feel. There will be a point at end inspiration, at the end of taking a breath in, when those pressures are going to equilibrate. So the pressure inside of the chest or the pressure inside of the lungs will now be equal to the pressure at the mouth. And then we will have a situation, and you'll notice it says that at end inspiration, uh, the gradient is zero. So the gradient there becomes zero. There's no more pressure difference. So now airflow stops or it ceases. Then we're going to transition into exhalation. So those ventilatory muscles, they are now going to go from being contracted, they're going to relax. You've got elastic recoil forces of the lungs. Remember, the on inhalation, the chest pulled, the chest wall moved outward, and that the diaphragm went down and the chest wall moved outward, and that facilitated creating that pressure difference so the air can go inside of the lungs. Now those pressures equilibrated, and now we're going to have the relaxation of those muscles. So you're going to have the diaphragm moving back to its high position, uh, and the elastic recoil fibers within the lung are going to close down. So now we're going to have a situation where the pressure inside of the chest is now greater than the pressure at the airway opener, the pressure at the mouth. So that's going to facilitate that creates a pressure gradient, and that now allows high pressure inside of the chest to move to low pressure out here in the atmosphere until you're able to exhale. And then at end exhalation, you're going to have a situation where those pressures are equivalent again. Because do you perpetually continue to exhale? No, you eventually get to a point where you can't blow anymore out. And you also notice that you get to a point to where to exhale, you'll have to work harder to blow out more exhalation. And we'll go over those lung volumes here in just a moment when we get to that section here in just a few PowerPoint slides. So I'm making up, see, we've got a question in the chat box. Let me take a peek at it right quickly. Yes, ma'am. Let's have it.
Okay, yeah, it's easier to speak it than it is to type it. So as far as the where we're at on this slide, describing how air is moving or the pressure gradient is changing as it moves through the different pressure gradients. That slide where you're looking at lung to thorax pressure gradients,
Mhm.
it has them labeled the first one trans respiratory pressure, the second one transpulmonary pressure, and the third as transthoracic pressure. But my question is, that's not necessarily the order in which airflow and the pressure is interacted. Yes, baby, hold on. So it does that mean that it starts at the you were describing how we're at sea level and pressure at the outside of the mouth is oh, I'm so sorry.
It's all
I
good.
have my littlest little distraction here.
Hey, we're doing what we got to do. It's all good.
Right. So you were describing how the pressure at sea level creates a pressure gradient at the mouth and then it moves downward. So that first zone that it would move into after its pressure's changed at the mouth, air moves down the into the trans or into the windpipe. Essentially, is that where the trans respiratory pressure gradient is located?
Yeah, try to just understand the general concept. I know that illustration is showing that this pressure pointing toward the trachea, this pressure pointing to so the the transrespiratory pressure or your trans airway pressure is going to be the pressure through the airways. So it is good that that points to the trachea, but ultimately what that does just kindly depicts pressure across the airway. We also have pressure across the lung and of itself, and then there's going to be your transthoracic pressure, which is the pressure across the chest. So
So
uh,
it's more of zones, not so much specific locations. It's more of
correct. Yeah,
okay.
generalizations and concepts. Yep.
Okay. So but and then my follow-up question to that was um so then the order is it sounded to me, correct me if I'm wrong, that the order of which the pressure gradients the air is moving down through the pressure gradients would be the trans respiratory pressure and oh my goodness, I'm so sorry. Uh Pressure in the trans respiratory pressure zone decreases, pushing the gradient to move airflow into the transthoracic pressure zone. So it goes from respiratory to the thorax, transthorax, then to transpulmonary.
The you have so a pressure exerted across the airway, a pressure exerted across the lung parenchyma, and then I went across my chest, but I can't reach inside of my body and grab the lungs. But then there's a pressure that gets exerted across the actual chest wall and of itself. I'm trying to understand exactly what it is that you're asking.
Yeah, I'm doing a poor job of it. Forgive me.
No, no,
I
not at
guess
all.
to be more clear, is the order of these pressure gradient zones listed in order that it occurs. One,
Um,
two, from
oh,
top to bottom.
So to an extent, yes, but they're also going to occur simultaneously.
Oh, okay.
There's going to be a fluid movement. If I mean, obviously the airway pressure stuff has to occur first, but then as the lungs begin to fill, you're also going to have pressure that fills in the lungs, and then there's going to be a pressure on the chest wall as well. So to an extent, it happened. I mean. I don't think we should get caught up in a step one, step two, step three kind of ordeal, but understand that as you take a breath in, these pressure gradients are going to occur.
Okay.
Does that help?
I'm sure it will. You're getting through this pretty well, so I'm gonna give it a few more slides. If I'm still unclear, I'll come back up.
Okay,
Mhm.
fair enough. Uh, so at this point, like we said, you're going to have an increase in your pleural pressure. Uh, and that's going to help that pressure change. So pressure now greater inside of the chest is going to help to move that alveolar pressure greater than airway opening pressure. And now when alveolar pressure is greater than your airway opening pressure, so pressure inside of the chest, inside of the lung, is greater than the pressure at the mouth, that's now going to facilitate the movement of air out of the lung. So that is exhalation. And then you're going to get to a point to where you're going to stop exhaling, those pressures will equilibrate, and then now you got to wait for the next diaphragmatic contractual event for the whole process to be reversed to where now pressures more negative on the inside of the chest than it is at airway opening pressure. So kindly look, and you can see these numbers and so forth, and you can see how your transrespiratory pressure, the transpulmonary pressure, you can see how those alveolar pressures and so forth are going to change. So notice this is going in a circle, so it's cyclical. So you're going to have, so ultimately you have end expiration listed over here where my cursor is. You have end inspiration listed over here. So I also want you to note that if this is end expiration, so I have stopped breathing out. That also means that at this point is the beginning of inspiration. So this is going to be when we have the beginning of inspiration. Now you inspire, those pressure differences change. And now we're going to have a situation where we are able to have end inspiration. But if this is end inspiration, it's also the beginning of exhalation. Uh, and to your question, Faith, if you were wanting to, this little box down here where it has the mathematical components, that's kind of the transition of those pressures that I believe you were asking about. So this slide, if you can, may should help with kind of what you're asking to kind of see that everything occurs rather simultaneously. So in this case, at end exhalation, alveolar pressure is equal to our airway opening pressure. So what does that tell us? There is no airflow that is occurring at that point. Um, no airflow that's going to occur at that point. Diaphragm is then going to contract, and you will notice that we've got a greater, by greater, I mean a larger negative number in that pleural pressure, and that's going to cause us to have a negative pressure and a negative alveolar pressure. Well, -1 is less than zero. Does that mean, uh, and these numbers are somewhat to an extent arbitrary, but they show the relationships that we've just previously discussed on the last couple of slides. The alveolar pressure and inhalation is negative. So if this is negative, you'll notice now that this blue arrow shows up in the trachea or the airway to demonstrate that there's airflow going into that chest, and that's going to occur until now we get to a point to where um, and you'll also notice your pleural pressure, the pleural pressure, uh, it's 10 and 10 or -10 and 10. So that's going to equate to an alveolar pressure of zero. So at end inhalation, those pressures are going to equilibrate. Now that those pressures have equilibrated, you're going to see, and that is the elastic pressure, PEL, or the elastic pressure. You're going to notice that elastic in uh, the elastic forces are going to begin to occur. Let me see, there's something in the chat box. That's correct, Kayla. This is just a picture that kind of demonstrates what we've been talking about over the last couple of slides. Yep, absolutely right. Uh, but now if alveolar pressure and airway opening pressure is zero, you'll notice there's going to be no flow. So you're going to have an increase in those elastic recoil forces. It's going to move the elastic recoil force, the arrow goes inward because that's the direction that the lungs are going to move. So at end inspiration, we also begin to exhalation. So now that elastic recoil force is now 7. So there's a pressure difference between the elastic recoil force, that pleural pressure, which is going to give us an alveolar pressure of 1. That alveolar pressure mathematically is greater than 0. So that's going to allow us to have the outward flow of gas. So you'll notice that arrow, that blue arrow showing the air is moving out of the lungs and out to the airway. I would really encourage you for the purposes of mathematics and so forth. I mean, we need to know that you will have negative numbers on the inside of the chest. There'll be, but the numbers inside of like your alveolar pressure is not always negative. It's negative when you have inspiration occurring, and it's positive when you have exhalation occurring, because there has to be a pressure difference in order for air, a negative pressure difference in order for air to go into the chest and that pressure has to be positive in that one. So if you leave airway opening pressure at 0 or 760 millimeters of mercury, it's probably just a little bit easier to use 0 and 1, but we'll call airway opening pressure 760. When we uh, take a breath in, the diaphragm's got to contract. It's got to drop the pressure inside of the chest. So it has to be less than 760 or less than 0. And it's going to be, if we're less than 0, it's going to be negative. And that depicts that negative pressure change that you have to have in order for air to go inside of the chest. Then when we get over here to this point, those pressures are going to equilibrate. So now we get to a point where we've taken in enough air into the lungs to where the alveolar pressure is equivalent to what our airway opening pressure is. Here it's depicted by 0. So airway opening pressure is 0, alveolar pressure is 0. And we also said that we have elastic recoil forces of the lung. So that PEL is the elastic recoil force of the lung. And you got an inward arrow showing there. So our lungs have a natural tendency to want to recoil inward. As those elastic fibers begin to close the lung down, it's now going to cause there to be a greater pressure inside of the alveolus, where you can now see that depicted as 1. 1 is greater than 0, which is the airway opening pressure. So the overall gist that I would really hope that we hit home is pressure moves from an or flow moves from an area of high pressure to an area of low pressure. During spontaneous ventilation, the diaphragm will contract. At that point, the diaphragm contracts. It generates a negative pressure inside of the chest, inside of so your alveolar pressure becomes less than what the airway opening pressure is. If there's more pressure at the mouth than there is at the chest, that's going to facilitate air going into the chest. That inward flow, that inspiratory flow has to stop at a certain point. That's going to be when the alveolar pressure now equals your airway opening pressure. So I'm moving the cursor over here where we can see this. Alveolar pressure is 0, airway opening pressure is 0. There is no more flow at this point. Now those respiratory muscles are going to relax. The elastic recoil forces of the lung are going to take over. And as those elastic recoil forces take over, they begin to generate more pressure. They're pushing on, or yeah, they're applying pressure on the alveolus. So that generates pressure in the alveolus. In the alveolus. So now your alveolar pressure is 1, as opposed to where your airway opening pressure is 0. So there's now a pressure gradient again, or a pressure difference. So now the fact that the pressure is greater inside of the chest than it is at the chest wall, now that air can move out of the chest until those pressures are 0 again. And now you're going to have a situation where the diaphragm contracts. So if we have a normal respiratory rate of 12 to 20 breaths per minute, and I know there's a little bit of variation, male versus female, but generically 12 to 20 breaths per minute. Uh, every time you take a breath, this is what's physiologically happening with the lungs and the pressure changes that are there. Does this help it make a little bit more better? Is this a little bit easier to understand, or is it still confusing?
Now, yeah, much easier.
All right, sweet, very good, sweet, awesome. So we will move forward then, and if you have any questions, feel free to throw it in chat. I'm not opposed to you just unmuting also, in case I don't happen to see the little notification that I get when there is a question in the chat box.
Oh, one more question.
Yep.
When you were going through the phases on this diagram, at the section of end of inspiration, end of inspiration, you got the force of the pull of the, I guess I'm trying to remember. The recoil portion of this happens after you breathe. Trying to draw and write, and I'm doing a bad
Yeah. So if you're at end inspiration, so if my hands are kind of indicative of the lung, if I'm breathing in, they're going to expand outward. I'm going to get to a point where they stop expanding. At this point, that's end inspiration. So now if my fingers and everything are the elastic recoil forces, those elastic recoil forces have a natural tendency to want to go back down. So they're going to begin to compress on that lung tissue or that alveolus. And now, as it does that, it's going to generate more pressure inside of the lung. And that pressure is now going to allow the air that's in here to be pushed out of the airway and breathed back out into the atmosphere.
Okay.
Good deal. Uh, And then this talking about our intrapulmonary and intrapleural changes that we can see here. So, if you didn't like that particular illustration, this illustration may make a little bit better sense. But upon inspiration, we know that diaphragm is going to move in the downward direction. As that diaphragm moves in the downward direction, we get a negative pleural pressure, but we also have a negative alveolar pressure. That negative out, it's not really depicted well in here, but that's going to allow the chest wall is going to move outward. As that chest wall moves outward, the diaphragm moves down. It's also going to facilitate these lungs in expanding. So as these lungs expand, that air is moving in. We're going to have a point somewhere right here where, and it's not depicted, but those are going to equilibrate. So gas flow is going to stop going in. So now you can see that the lungs are going to recoil inward. As those lungs recoil inward and as those muscles of ventilation kindly relax, the chest wall is also going to move the same direction now because the lungs are going to pull the chest. Here, the chest pulls the lungs out. And here being inhalation, chest pulls the lungs out. It's going to facilitate making the pressure differences necessary for air to go into the lungs. As we get over here, as we move this direction, at a certain point, chest wall stops moving out, lungs stop inflating. Why do they do that? Because there's no longer a pressure difference. Pressure's equal at the mouth, pressure's equal inside of the chest, with alveolar pressure is equal to the airway opening pressure, and it stops. It being flow, flow stops, inspiratory flow stops. Now we get over here to the exhalation piece of this, and you'll see that the lungs have that inward recoil. The lungs are going to move in, and as they move in, they're going to pull the chest wall back with it. And once that elastic force begins to close the lung down, if you will, it's going to generate more pressure inside of the alveolus. So the alveolar pressure is going to be greater than the airway opening pressure, and that's going to facilitate air moving out of the lung and into the wall. Essentially, the exact same thing as on the previous slide, just depicted in a different manner. And then we also have this slide here, and we don't want to get too terribly complicated, but this slide goes along with this concept question. So this concept question, I don't know. So slide 12 and slide 17 go together. The questions asked there, we get a little bit of explanation of how inhalation and exhalation works under spontaneous conditions, and then you get this graphic that on the left side, so over here, this is spontaneous ventilation. This is how you and I are breathing right now. Over here, where it says positive pressure ventilation, this is a patient that does have either some type of interface, whether it's a mask or an endotracheal tube, and they're attached to a machine, and that machine is blowing air into the lung. And the reason you see that the airway opening pressure is 0 and the airway opening pressure is 10 here, that 10 represents the positive pressure from the machine that they're attached to, as opposed to where over here, airway opening pressure being 0 is indicative of atmosphere. So the diaphragm's got to contract to drop that pressure. So our pleural pressure is 10, and so that the difference is when the diaphragm contract, pleural pressure of -10 is going to help to facilitate that 500 cc's of volume getting into the lung. So as that 500 cc volume is in there, you're at end inspiration. So alveolar pressure equals airway opening pressure. There is no gas flow that's occurring. So this is if we're saying you've got a tidal volume of 500 in the lung at this point, this is at end inspiration. So at end inspiration, we have 500 cc's of volume inside of the lung. Now those elastic recoil forces are going to uh, make that pressure become one, which is greater here. That would facilitate exhalation under normal circumstances. So over here, when you attach a positive pressure machine, such as a mechanical ventilator, a CPAP machine, a BiPAP machine, however the interface is you want to use, and there are different interfaces. We're going to go over those uh, later on. You'll see some in clinical, and then we'll have a competency evaluations and so forth on all of that when we get to the summer semester. But now we can see that when the inspiration gets applied, that alveolar pressure, which again is the machine that's going to push or force that air into the lungs. So we're now have and again we'll utilize 10 as our number for pressure at the airway opening pressure. 10 centimeters of water pressure is being applied to the airway because we're attached to a machine that's blowing that in our face, or not in our face, but down our trachea. That same pressure gets exerted to the alveolus. So at this point, the amount of pressure that I'm applying to get that 500 cc's of volume inside of the chest, in both situations, the end result is you take in a 500 milliliter breath. You've got 500 milliliters at the end of inhalation. You have the same amount of volume in. The difference here is how that volume got there. In spontaneous ventilation, the diaphragm contracted, the pressure gradient. I'm not going to keep saying the same stuff over and over again because I know you've probably got it by now. But the difference is how the volume got in there. When we're looking at a positive pressure breath or positive pressure ventilation, we've applied a specific pressure to the airway. That pressure now gets transmitted to the alveolus to get the same tidal volume in there that once. So 500 goes in there. You'll notice that that pressure being applied to the airway is going to have an impact on the pleural pressure, but our alveolar pressure is now 10. Uh, the alveolar pressure is now 10, airway pressure is 10. So at this point in time, there is no movement of air. And I don't want you to think that a mechanical ventilator like sucks the air out of a patient because it doesn't. Once those, so we apply the 10, if we're using 10, you apply 10 of pressure, the airway, that 10 goes down to the alveolus, holds it up, which stretches the alveolus just like it would with spontaneous ventilation. And you still have those elastic recoil forces, and you have a point with a mechanical ventilator where you set a respiratory rate, you set a tidal volume, what have you. The machine is going to blow that 500, deliver the 500 milliliters to the lung, and then the lung opens up, and it's no longer getting the five because the pressures have equilibrated. It is pushed in the 500 that it's going to get. Well, now exhalation is still going to be a passive process because those lungs have been inflated. So the exhalation piece of this is the exhalation piece of both of these are going to be the same as long as you are allowing for an adequate time for exhalation to occur if we're hooking somebody. And we'll talk time constants and stuff. We will talk about that on day 2 of this presentation. But you've got to understand there is a difference in how the chest responds basically to spontaneous ventilation to mechanical ventilation. Uh, and we will talk about the hazards and stuff associated with that later. Right now, I want you to know there's a difference. We'll talk about that difference and specifically what it is when we get to mechanical ventilation.
Question.
Yep, what's up?
Um, for that last slide, are there any instances where mechanical breathing could be impeded by like a neuromuscular disease or something, like where the diaphragm has some type of dysfunction, where that would that change anything about the mechanical breathing needs?
So if someone were to have a neuromuscular disorder or a paralyzed diaphragm, if I'm understanding what you're asking correct, at this point, a neuromuscular disorder is really gonna uh, decrease the ability of the spontaneous ventilation mechanism to work. So those individuals are going to require mechanical ventilation or ventilatory support because their respiratory muscles are not able to generate those pressure differences. Or the energy to produce those pressure differences for ventilation to occur. So, if someone has a progressed neuromuscular disorder that's involving the diaphragm or they've got diaphragmatic paralysis, then yes, you will be heavily dependent upon uh, the um, the machine to inflate the lung. But as long as there's not any additional pathophysiology, and for all intents and purposes, we'll say we have normal lung tissue, the exhalation piece of that should still work appropriately as long as the lung parenchyma itself is not damaged by the disease process. Does that make sense?
Yes, that's what I was asking. Thank you.
Yep, very good. All right, so now we get into the lung volumes and the capacity. So we've covered the mechanics of ventilation. Hopefully, it's not clear as mud. Hopefully, it makes pretty good sense. And we'll get into our lung volumes and or capacity. So important to understand that you have uh, four lung volumes and you have four capacities. A capacity is made up of two or more lung volumes. So let's take a look at our spirogram. Well, we'll look at the spirogram here in just a moment. So with spirometry, you're going to have to measure your lung volume. So if you're going to measure lung volumes, you're going to utilize a spirometer to measure lung volumes, and those are going to show up on a spirogram, which is a picture of those lung volumes. So if you're going to measure volume, you utilize a spirometer. If you measure flow, you utilize a pneumotachometer. But for the purpose of what we have here, we can just focus on the spirometer in of itself. Uh, so you're going to have your patient breathe in and out, inhale and exhale through a specific tube that goes to the instrument, and then that's going to be kind of where you get your spirogram from. And in your book, I believe it's also on the next slide or two here, but it depicts um, how like a water seal spirometer would work to produce the normal spirogram that we'll look at. So the tidal volumes that we'll look, not the tidal volumes, but the volumes that we do tend to look at, you look at what your tidal volume is. That's the volume that you and I breathe in and out normally. It's going to be I know that you've probably touched on these a little bit when you went over PFTs in the startup of your pathophysiology course. You need to make sure that you understand the lung volumes, the volumes that make up which capacities, and where you're at. Because when we get into mechanical ventilation or we talk about breathing, we may say a vital capacity, we may say functional residual capacity. These are going to be things that we want to make sure that we have a true appreciation for, uh, and can it just helps if you understand the terminology. That way you can know what volumes and or capacities are being talked about. And I will pull up here in just a moment and kind of let me do it right now while I'm thinking about it. So let me just kind of impress upon you. Now it may only be one or two questions like this, but I'm going to hit the exit tab. I'm going to pull up uh, Google, or not Google, but we'll go to the nbrc.org. That is the National Board for Respiratory Care. So this is the credentialing agency for the credentials that you aspire to obtain. Now you'll probably, although you're taking the RTE, what I'm going to pull up is the free practice TMC exam. Uh, but I would imagine a lot of the question, because the detailed content outline is still very similar. So it's possible that you'll see a question as such. So if I click on this free practice exam and I click on the TMC practice exam, we're not going to take this practice exam, but I know that early on in the exam, there's a question uh, that kind of includes these lung volumes and so forth. So it should hopefully just provide a good example as to why it's important to understand the lung volumes and the capacities. Because if you don't, then this is a question that you're going to likely miss unless you're just a really good guesser uh, on the board exam when you take it. So it's not there, not there, not there, not there. This one. So you have and we're not going to spend a massive amount of time because we're getting ready to get into those, but I just wanted you to understand this gives you a vital capacity, a functional residual capacity, and an expiratory reserve volume. And it's going to ask you what the patient's total lung capacity is. Well, if you've not ever spent any time looking at those or reviewing any of that stuff, it's going to be difficult. This can be solved and needs to be solved with math. But in order to do the math to be able to figure out this question, you have to remember what lung volumes make up which capacities. And then you'll have to kind of do process of elimination. So we'll come back to this question. I'll leave it up after we go over some of those volumes and we'll figure out what the answer is. Something in the chat box. Let me take a piece of it. FRC cannot be measured by spirometry, or am I wrong? So you can estimate your FRC. I mean, you can go through and do like nitrogen washout and stuff because you got to figure out what the residual volume is. But uh, at the end of an exhalation, you are at your FRC. Uh, so we'll talk more of that in just a moment if that's okay, Journey. Mm, Sweet. All right. So from the current slide. All right, so we'll go on to so we talked about the water seal spirometer. Essentially, what you have, you've got a water column and so forth. There's a pin attached to it. As the patient breathes in and out, this column moves up and down. It's attached to that fixed pin, and it gives you. I'm pointing to my screen like you can see what I'm pointing at. I'm sorry. You have the fixed pin there, and then as this column moves up and down, it's going to drag this pin with it, and this is uh, wheel is going to rotate, and as it does, it draws the spirogram on there, which takes us to what the spirogram is. So we said there's four lung volumes and four capacities. Let's go over the volumes first. You have your this volume to this volume, or excuse me, this point to this point is considered your inspiratory reserve volume. So IRV, I'll do a little drawing on the screen. Maybe if I can find. Well, I'll just try to do it with the mouse. No, it's over here. I gotta grab it. I'll be right back. Now let's plug and play right quick. I think this will help. I don't have a whiteboard per se so I have to draw just on the screen, and hopefully this will help it make a little bit decent sense. So if if let's change colors. Go to So essentially from here to here, this is your IRV, your inspiratory reserve volume. This volume here is your tidal volume. This volume from here to here is your expiratory reserve volume. And then from here to here is the residual volume. So now we need to understand. So those are your four volumes. So the maximum amount that you can inspire above a normal tidal volume is your inspiratory reserve volume. The amount of volume that you breathe in and out normally at rest is the tidal volume. The volume that you have left available. So, all right, so if I really enjoyed listening to Whitney Houston sing growing up. She could hold a note. There's some phenomenal singers out there. Got Adele, Jennifer Hudson, she's a good one. So these individuals that can really hold these notes. I maybe it's a little nerdy of me, but I always think it's quite an impressive expiratory reserve volume when they get up there and they're holding that note really well. That's how they continue to hold the note is because their expiratory reserve volume. It's the amount of volume left in the chest after a normal breath. So also that would be how I could continue to talk and talk and talk and talk and talk and talk until I can't talk anymore. Right now, I'm working my way through my expiratory reserve volume. There's not much volume left in the chest, and you can begin to tell that my voice is beginning to kind of strain. I'm having to really push to get it out. I can't talk as much anymore, so I have to take a breath in. So at that point, at that point, I had pretty much blown out all of my expiratory reserve volume, which left me, I was getting close to what my residual volume is. Now, the residual volume does not come out of the chest. It's an amount of volume that stays in the chest, and it's difficult to be able to measure that residual volume unless you were to do like a helium dilution, nitrogen washout, or body plethysmography with specific pulmonary function equipment testing and so forth. So I like to think of uh, these volumes. I like to remember them mathematically with the capacities. So you know that you have total lung capacity, TLC. Well, that's going to be equal to all of them. So IRV plus tidal volume plus ERV plus RV. Total lung capacity is all of the volumes together. Then we have a vital capacity. That vital capacity, if I wanted to do a vital capacity on someone, what I'm going to do is I'm going to have them take a breath in, breathe in as much as they can, fill their lungs up as full as they can, and then I'm going to have them exhale. And it's not really depicted as greatly on this spirogram because if it were, let me change colors real quickly and I'll show you in a spirogram format what that would look like. So if I change back, so I'm going to breathe, tidal breathe, breathe in and out normally through your mouth like you can, tidal volume, moving tidal volume. Now I want you to take in a deep breath as full as you can, fill your lungs up as full as they can, full as they can, full as they can, and then blow out as long as you can, as hard as you can for as long as you can, this and that, and then blah, 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 blah. And then you're right back up to normal tidal breathing after that. So here is your tidal volume. This is your inspiratory reserve volume. This is your expiratory reserve volume. Down below that would be your residual volume. You cannot get rid of the residual volume, and you can't necessarily directly measure that, but you can get an estimate of it through, like we said, uh, um, those tests that I just mentioned: nitrogen washout, body plethysmography, helium dilution, and the like. So vital capacity, you have the patient take the deep breath in as much as they can. That's the IRV, inspiratory reserve volume, plus tidal volume, plus expiratory reserve volume. So those three volumes, this volume, and this volume, make up your vital capacity. So total lung capacity, vital capacity. We also have an inspiratory capacity, an IC, and I probably should have listed that one before the vital capacity, but it's okay. The inspiratory capacity is two volumes. Inspiratory capacity is how much can you inhale? So that is going to be your inspiratory reserve volume plus tidal volume. And it doesn't matter if you switch, if it's tidal volume plus IRV, it don't matter. You're going to get the same answer. Two plus four is six, four plus two is six. You're going to get the same answer. It doesn't matter however you want to organize that, that's fine. So we've talked about total lung capacity, vital capacity, inspiratory capacity, and functional residual capacity. FRC. You are at FRC at the end of a normal exhalation. So at the end of, so you're breathing in and out normally. And at this point here, I have breathed out or exhaled to my FRC. FRC is ERV, the expiratory reserve volume, plus residual volume. So mathematically, those help me when I'm working that out. So if I transition from, I'll clear that off the screen and just generically we'll go back to that question on the, I got to close that before I can do that. So now I'll pull this back up wherever it's at, and I'll see if I can annotate some stuff again. And so now this tells us, let me see if I can move this bar out of the way because it's keeping me from being able to read it. There we go. So can I write on the screen? Yeah, I can still write on the screen. So we know that our vital capacity equals 3.6 liters. FRC, what makes up FRC? FRC equals ERV plus RV. Vital capacity is IRV plus tidal volume plus ERV. We're given that vital capacity is 3.6. We're given that FRC is 6. We're given that ERV is 1. So how do we answer this question? Well, if you know what volumes make up what capacities, then if I look at FRC being uh, 6 liters, or excuse me, yeah, FRC is 6 liters, and I know that the two components to that is residual volume and expiratory reserve volume, and I'm given that my ERV is 1. So if this is 1, ah, if ERV is 1, and I know that FRC is 6, then what must RV be? Well, 5 plus 1 is 6. So RV has to be 5. My residual volume is 5. Well, the question's not asking you for what residual volume is. It's asking you for what TLC is. Well, if you know that vital capacity is IRV plus tidal volume plus ERV, the only component missing for TLC at this point, IRV plus tidal volume plus ERV plus residual volume. You're given that vital capacity, which we've stated encompasses these first three volumes. Vital capacity holds those first three volumes, and that's 3.6 liters. Well, we found out through knowing what volumes make up what capacities, that our residual volume is 5 liters. So now we just got to take 3.6, add to that 5, the 5 liters to that for an answer of 8.6. Let's look over here. Is 8.6 an answer choice? It absolutely is. And that's what we would select for that test question. So you probably, I can't say you wouldn't have a question like that on your very first test. But you can see how you're learning that now. You don't take your board exam until another year from now or a year and a half from now. This is information we're going over. This is going to be stuff that you'll need to make sure that you just don't learn for a test, but you that memorize for a test, but you actually learn it so that you can apply it later on down the road. And I promise the normal spirogram, ERV, all these volumes, all these capacities will continue to keep coming up as you move forward. So let me clear those, close that, and then I'll get back to the presentation. Um, any questions about the lung volumes and capacities? Pretty self-explanatory stuff if you look at it. I mean, you should be able to draw a normal spirogram and label it with what the uh, uh, label it with which volumes make up which capacities and so forth. And if you can remember them as such, then it makes it easier to work out one of the problems like we just did on the board. This gives you the definitions and the overall symbols for how you might see them. Now you'll notice that when I wrote tidal volume, I wrote it with V and a capital T in the subscript. That's absolutely how you can write tidal volume, or you may also see it as abbreviated as TV. So make sure that you pay attention to that too. But ultimately, it gives you the definition for all this. And like I said, residual volume doesn't come out of the chest. Those of you that may have worked as a CNA or what have you, if you've ever been tasked with taking a body that is passed to the morgue, you may have heard that residual volume come out when you move the patient and they go that's what bit of volume is left in their lungs is coming out. Uh, but under normal circumstances, residual volume stays inside the chest. You don't get rid of it. Journey, you had asked a question a little bit earlier. Does this help with that question that you asked? Excellent. Very good. All right, we'll keep plugging. So if we look at this concept question, it asks what effect would an increase in residual volume have on the other volumes and or capacities, assuming that TLC stayed the same. So if total lung capacity stayed the same, meaning that the lungs can hold X amount of volume, so if they can only hold uh, for grins and giggles, we'll say they can hold 10. And then, I'm not going to go through and try to break up your IRVT, tidal volume and stuff and that. But let's just say it can only hold 10 liters. Uh, if your residual volume becomes increased, that means air that's trapped in the chest, the residual volume never coming out, then that means those other volumes and capacities are likely probably going to be smaller. And if you'll think of kind of an increase in your, if you think about it and apply pathophysiology, if residual volume come, what disease process do we know of that causes air to be trapped in the chest and not ever be able to get out? Somebody put it in the chat box or unmute and tell me right quick. Yes, race, very good. COPD. COPD is exactly right. So like we said, the compliance may actually go up a little bit with that disease process, but the actual amount of gas that they can move is going to be a little bit smaller because they've got trapped air inside of their chest. So this is a great concept question, and I hope that it intuitively makes pretty good sense. These things that we're talking about here are going to be, so somebody had asked about neuromuscular disorders. It was Faith had asked about neuromuscular disorders a little bit ago. These are going to be some measurements that you also see to help gauge an individual's respiratory muscle strength. So you have MIP and MEP. MIP is maximum inspiratory pressure. I'll also mention that you should be on the lookout for some text that might say a NIF, negative inspiratory force, NIF. MIP and NIF are essentially the same. Also, depending upon which book it is that you're looking at, you may notice that you have units of measurement in centimeters of water pressure, or some books may utilize millimeters of mercury. I believe they're trying to move more the route of centimeters of water pressure, but you may come across some millimeters of mercury, and you could see some of that on your test too. So pay attention to the unit of measurement for these items. But these are, so MIP is how strong can we breathe in? So how do you do a negative inspiratory force or a maximum inspiratory pressure on an individual? You ultimately are going to have their nose pinched, and through a mouthpiece, or if it's in a tracheal tube, you're going to have them breathe in as hard as they can. And you want to make sure that they are able to breathe in greater than negative 20 centimeters of water pressure. If they are only able to pull negative 10, negative 5 with a maximum inspiratory pressure or negative inspiratory force, that essentially means their diaphragm's not able to generate enough pressure to facilitate spontaneous breathing. So at this point, we might would decide to utilize adjunct therapeutic means, whether it be BiPAP, uh, or in some cases, it might mean we go straight to intubation and mechanical ventilation with that. The MEP, maximum expiratory pressure, is how much positive pressure they can generate by blowing out. So it'd be essentially the ability, I don't want to call it the ability to cough, but the ability to how much pressure they can generate as they blow out. And because that is coming out, that will be a positive number. Maximum inspiratory pressure will be a negative number. So MIP is negative, MEP is positive. Um, We're also going to begin to look at some of these static pressure volume relationships. We'll talk about Hooke's law and elastic recoil. So Hooke's law, which is depicted, I think, on the next slide, just basically, if you can remember how we talked about the Frank Starling mechanism early on with the heart, the greater the stretch, the greater the force of the contraction. That's kind of similar in nature to the elastic recoil force as Hooke's law would state. So uh, the longer the pull, as far as the elasticity, the greater the recoil, if you will. We'll look at static pressure volume curves too. We'll discuss hysteresis and kind of what becomes with that lung distensibility, and then we'll talk about compliance and lung volume as we look here. So you can see they utilize springs, and that's pretty good that they'll spring. So that they utilize springs. So we have a compressed spring, and then ultimately it can be stretched to an extent, but as far as it's stretched is going to be how far it can go back as well. Uh, so do keep in mind though that what's depicted here is linear, and that's not necessarily the case with the lungs. With the lungs, you're not going to get a linear curve like this, you're going to have more of a sigmoid or S-shaped curve, and we'll look at some of those moving forward. But make sure that you can, as far as like the test question breakdown on your MBRC exam, you've got application questions, recall questions, analysis questions. Hooke's law, if we're applying it, probably going to be more along the lines of like a recall type question, just making sure that you understand uh, that relationship. So I talked about it producing an S-shaped curve, if you will. So we have the inspiratory limb of this pressure volume curve here, and you'll note the direction that the arrows are pointed. You're also going to have an expiratory limb, and you'll notice that while those curves are similar, they are different because they're going to produce different shapes because inspiration is active as opposed to where exhalation is passive. And when you're looking at the X and Y axis, you can see on the vertical axis, we're looking at the volume or percent of your total lung capacity. So how much volume is in that total lung capacity in relation to what the transpulmonary pressure is along the horizontal axis. And those are centimeters of water pressure. We'll not get hung too much up in that right now, but you'll notice that you have this LIP and this UIP. So this on the inspiratory curve is a lower inflection point. That's what LIP stands for. And then we have an upper inflection point. Uh, we'll talk more about those in a little bit more detail when we get to mechanical ventilation, but for uh, kind of what we'll look at is at the lower inflection point is when you begin to get alveolar recruitment. So it would make sense if you were going to apply positive end expiratory pressure or PEEP to begin to try to look at setting your PEEP along the lines of where that lower inflection point is. The upper inflection point is kind of the point to where you begin to look at the possibility of over distension of the alveoli. So we will talk about damage that can occur to the lungs by way of either volutrauma or barotrauma. That's terminology that you don't need to necessarily worry with too much at this moment, but when we get to mechanical ventilation, it will make more sense. But this is the groundwork for, these are the building blocks for what we're going to build upon when we get to that mechanical ventilation course. So if we tend to venture up over that upper inflection point, it's possible that we're over distending the alveoli or stretching those alveoli too far. And if you continue to stretch an alveolus so far, it could potentially burst, lead to damage to the alveoli and so forth. Uh, so we can also see that the expiratory rate and kind of the difference between the two of those, if you were to draw a straight line in between, is where the hysteresis is going to um, be formed. So what you see on this graphic over here between A and B is ultimately the way in which we ventilate our alveoli are, for the most part, going to stay relatively uniform in shape and size. You're not to say that you couldn't ever have one that's bigger than another, but the overall goal is that all the alveoli inflate to essentially the same size. And what you can see here in this top bit is you've got some alveoli in between like 1, 2, 3, and 4 there that are collapsed down. So now we've got to hit to that lower inflection point where we begin to get our alveolar recruitment. Alveolar recruitment means that we're opening up the alveoli so that they can receive that volume and now be a functional respiratory unit that's going to participate in gas exchange. Here we're going to have so just to recap, uh, if I'll draw just a little bit. Uh, we have um, capillaries that surround these alveoli. And I'm doing a terrible job, but you can see that you would have capillaries that surround those alveoli. Even there's going to be capillaries on that alveoli. So when we talked about shunt versus dead space. So if I were to block blood flow through these capillaries and I still allowed that alveolus to be ventilated, I'm having ventilation without perfusion, which would be dead space. Here in these areas, you're going to have those blood vessels around these alveoli that are not opened up yet. They're not opened up yet, but that doesn't mean blood flow doesn't go through the capillary network. You still have blood flow going through. So that's a situation where there's perfusion and no ventilation. So that would be shunt. So now we hit this lower inflection point or the area of recruitment, we apply a little bit of positive pressure to the airway, and now, boom, from the transition from A to B, we now have those alveoli that were closed where there were uh, areas of shunt where there was perfusion and no ventilation, and now we've opened them. Now that capillary membrane, capillary network that surrounds that alveolus can now be a functional respiratory unit for us, and we can have gas exchange there. So from here to here, by simply opening up the alveoli that are present, we have improved our ventilation and perfusion matching or VQ matching. And those will be some more terms that will make better sense when we get to mechanical ventilation. But I know we've talked about shunt and dead space, so I wanted to try to provide that example while we were here. And that just kind of talks about now if these were to get grossly overinflated and squeezing and impinging or so that's a crowd. So now they're bumping into each other and they're getting enlarged. If they were getting overly enlarged, that's where we would be getting to that upper inflection point. And again, that'll make better sense when we get to mechanical ventilation in the summer. So as far as distensibility of the lung, we do look at compliance. Compliance, most easily stated, is the ability of the lung to receive volume. You're going to have dynamic compliance and you're going to have static compliance. There will be math involved, but like I said, there's not a significant amount of math on this first exam. There was one question. If you can cut a number in half, you should be able to perform the math on the first exam. But moving forward, you will be tasked, excuse me, will be tasked with calculating static and dynamic compliance. Static compliance, remember the term static and what it means. Under the conditions of no flow. Dynamic compliance, dynamic is moving. It takes into account moving parts. So it does incorporate airway resistance and so forth. So under the purposes of a normal spontaneously breathing individual, compliance generically is the formula for compliance. We will hammer down more specifics to the formula as we move forward, but generically, a change in volume in the numerator and a change in pressure in the denominator is going to be what our lung compliance is. Normal lung compliance, 0.2 liters per centimeter water pressure. And you're going to want to make sure that you pay attention if it's liters or milliliters because those numbers will be different. So if it's 0.2 liters, that means it's going to be 200 milliliters per centimeter of water pressure. So we need to look at that. So compliance generically is the ability of the lungs to receive volume or how easy it is to inflate. So if you have high compliance, they receive a lot of volume or they're easy to inflate. If you have poor compliance, they receive a little bit of volume and they're harder to inflate. So those are some concepts you've got to make sure that you understand because you'll hear compliance, airway resistance, and stuff like that as you transition into and learn more about those disease states. But remember, we talk about obstructive disorders and restrictive disorders. For the most part, with obstructive disorders, the overall lung compliance is a little bit higher because they're holding more air. But the focus is going to be on getting that air out of the chest. It's going to be difficult to get that air out of the chest. With a restrictive lung disorder, you're going to have a poor compliance or low compliance. So the ability of that lung to receive that volume is not going to be very good. And you're going to have to really work hard to inhale. So with obstructive disorders, you work hard to exhale. With restrictive disorders, you work hard to inhale. That's going to be important to remember too. And then we talk about elastance. So when we talk about compliance and elastance, they are the reciprocal of each other. So if you wanted to calculate the elastance, you just take the reciprocal of your compliance. So, and if you remember taking the reciprocal of it, you just basically divide it by one. This graphic depicts compliance and overall lung volume, and you can see that as compliance goes up, so does lung volume. These compliance curves, interestingly enough, what we're going to talk about, if you see this, um, I'll try to draw on the screen again. Uh, so if you see this curve with this one being, uh-oh, did it come undone? No. Well, let's see. I don't know. Must have unplugged or, well, it ain't working anymore. My pen's not working, so I'll just use the cursor. Uh, so this curve right here is your normal compliance and lung volume curve. So transpulmonary pressure down here, lung volume here. Under normal conditions, that's what it should look like. You'll notice there's a left shift and there's a right shift of normal. Left shift moves this direction, right shift moves this direction. You'll also notice that with a left shift, lung volumes go up, so compliance goes up. With the right shift, lung volumes go down, so compliance goes down. Also notice this with pathophysiology. Emphysema and asthma. What type of lung disease are those? Obstructive or restrictive? Those are obstructive disorders. Fibrosis is a restrictive disorder. We said that you're more highly compliant with obstructive disorders. The focus or the difficulty is getting the air out. With a restrictive disorder, lung compliance decreases, so the focus is you have to work harder to inhale. So if you have a right shift of that compliance lung volume curve there, or volume pressure curve, uh, uh, right shift is going to be that you're looking more toward a restrictive issue and less lung compliance. You have a left shift, you're looking toward an obstructive issue and higher compliance. Excuse me. So concept question. In quiet passive exhalation, which of the following requires the longest exhalation time? The person with high lung compliance or the person with high lung elastance? Again, this is going to take into account an obstructive versus a kind of a restrictive issue. If you've got high lung elastance, that's restricted. So that means that you have a greater ability of the lung to move back to its normal shape. And let me see, somebody put something in the chat box here. Very good. Excellent. So we're seeing some things pop in here. We're talking about last. So if we go back to, so which would require the longest exhalation time, high lung compliance or high lung elastance? High lung elastance, they're going to collapse pretty quickly. So those individuals are going to exhale pretty quick. If you have high lung elastance, you've got low lung compliance, which means you can't get a lot of volume in, which means it's not going to take as long to get. So actually, in normal passive exhalation without blowing anything out, if I have high lung compliance, I fill those lungs up with a big volume. Well, naturally, because there's more volume, it's going to take a longer amount of time to get that air out. As opposed to where if I've got poor compliance due to high elastance, that air comes out pretty quickly. Does that make sense? We see it in the chat box. All right. Yeah. All right. Very good. I see the light bulbs. Very good. Excellent. You guys are brilliant. I dig it. You make teaching fun, and I appreciate you. So we've talked about elastance and so forth. Yeah, so take a minute or two, run to the bath. It shouldn't take too long to get through the rest of it. But yeah, if you need to go to the bathroom, I'll set a 2 minute timer and we'll do that if that's cool. 2 minutes and then we'll get back at it. Is that cool? Very good. So we'll take a minute, take a break. All righty. Um, Hopefully everybody's been able to make it back. And like I said, there isn't but a handful of slides left, so I think we'll finish here in the next little bit, and then we'll have time for questions and stuff. And if you think of something later, you can send me an email, and we'll get after it like that. But we will hold off on part two until the next time that we're together to let this information digest, and then that'll also allow. Because that presentation is shorter than this presentation, so hopefully it won't take as long to get through it, and then we can do a review for the exam um, as we get there. So surface tension is the one of the forces that are going to oppose in inflation, if we will. So surface tension uh, is uh, when we take about Laplace's law, it is as the radius of a sphere decreases, its surface tension increases. So ultimately, if I've got a sphere and it goes or an alveolus, one alveolus, and it deflates. At its point of deflation, its surface tension is going to be highest, so that it becomes difficult to breathe if those alveoli collapse all the way down, and you've got to overcome the surface tension to inflate it. That's where pulmonary surfactant comes into play, and we'll talk about that here in a couple of slides. But the role of pulmonary surfactant is to provide an air-liquid interface for the gases to transfer back and forth across the alveolar capillary membrane, but it also reduces surface tension. And by reducing surface tension, it makes it easier for a patient to be able to breathe. So, for instance, we'll just talk about this briefly. They say the hardest breath that you'll ever take in your life is the very first breath that you take. And the reason being is you're not breathing air in and out of your lungs when you're in utero. When you're inside the womb, you're not moving air. You do have fetal lung fluid that you're moving in and out of the lungs, but you're not breathing any air. So you're going to a situation after you've been born to where hopefully that fluid is being pushed and expelled out of the lungs. And now those alveoli that have never had any air in them have to have air in them. So those alveoli are as closed as they're ever going to be. And you've got to generate enough negative pressure to overcome that surface tension to pop those alveoli open so that the baby can begin spontaneous breathing. Now, I will also say this, that they predict that that's the hardest breath you ever take in your life. I would I would suggest that the second hardest, let's see, there's something in the chat box. Oh, that's why they used to yeah, get to get a little motivation to get them going. Very good, Faith. I like that. Um, so they definitely do that. Um, I would venture to say if you've ever played, and you don't necessarily have to have a contact sport, but if somebody's ever run into you and had the breath knocked out of you or the wind knocked out of you, what I would tend to say, yeah, there may be some thought in that you tend to stun the diaphragm a little bit or what have you when that occurs, but ultimately we've talked about those lung volumes. When you get hit in the chest, that residual volume that never comes out, that jolt tends to maybe expel some of that residual volume. So those alveoli that have been held open from that tend to go back to their closed position. So then you spend a couple of seconds wondering if you're ever going to start breathing again. And that's because your body's actively working to generate the negative pressure to pop those alveoli open again so that you can start breathing. So surface tension is a force that opposes ventilation. And Laplace's law is associated with surface tension. It eventually states that as the radius of a sphere decreases, its surface tension increases. So in the case of an alveolus, as that uh, surface tension has increased and causes that alveolus to close, that last bullet point says that the surface tension is responsible for a very large percentage of the lung's recoil force. Yes, the lung parenchyma itself has these elastic fibers in it, but there's also surface tension that's going to play a role in that, and we'll talk about that in a slide or two when we have the graphic to illustrate it a little bit better. So if you see those, and you can do this, I've done it before. You can float a paper clip on top of water as long as you can get it on the water without breaking the surface tension. When you wax your car and car beads up, Uh, that's surface tension, what allows those molecule or those water molecules to kind of form, and the water beads up on the car. And that's also why you see these spiders and or mosquitoes that can land and kind of walk across water. They're not heavy enough to break the surface tension, so they don't sink. Now, a paperclip is made of material that is certainly more dense than water, so it will sink. Uh, if you can, and I've done it, and it kind of irritated me a little bit because it took me like 30 to 40 minutes to get one floated. I got it floated, and then somebody bumped the the table. It broke the surface tension, and then the paperclip uh, sank. Or if you stick your finger in the water, it breaks the surface tension, and then it sinks. It's probably why if you've watched these videos of individuals that will uh, jump from a very high platform into water, they may throw a rock, a large rock down before they jump into it. That's so that the rock hits before they do and breaks the surface tension of the water so that it's hopefully not like smacking concrete when they go when they jump. Uh, So again, it's going to provide the liquid air interface that we have. So there are some experiments that have been done with the lungs that can be read about, but I'm not going to ask you specifically about those experiments on the test. You do have an air surface interface, air liquid interface. Basically, what this means is it helps to that the uh, surfactant, uh, well, the surfactant produces the air liquid interface, but through surface tension, that also helps us with an air surface interface. So you'll notice the alveoli are able to expand and or contract, and that has to do with decreasing surface tension to a point, and then surface tension will increase again, and that'll facilitate the ability of the alveolus to close. With Laplace's law, this is where the role of surfactant comes in. So the role of surfactant is now going to allow for a bit more even distribution, uh, um, even distribution of the flow into each alveolar unit. As you'll notice, those alveolar pressures and one and so forth that are down here. So the law of Laplace, as the radius of a sphere gets smaller, its surface tension increases. And then we take into account the role of pulmonary surfactant. Pulmonary surfactant reduces surface tension. It makes it easier for an alveolar unit to open up. So if I'm looking at an alveolus and I have an alveolar, my hands are representative of the alveolus. On the inside of this alveolus is a substance called surfactant that coats that alveolus. That substance is going to reduce surface tension. By reducing surface tension, it makes it easier when I take a breath for that alveolus to inflate. Because that is coated on the inside of that alveolus, that surfactant does provide the air liquid interface that allows for the transport of gases such as CO2 and oxygen back and forth across the alveolar capillary membrane. But it also, as that alveolar unit gets bigger, or as that alveolus gets bigger, that surfactant that was pretty much coating the inside of that wall now thins out. As it thins out, surface tension increases again because the surfactant is not able to reduce the surface tension with that surfactant being as spread out as it was. And now that increases surface tension, which facilitates that increase in elastic recoil forces to facilitate the passive exhalation that we've been talking about. Uh, so you've got different types of pneumocytes within the body. You've got your type 1 pneumocyte, which is your regular respiratory epithelium. You've got your type 2 pneumocyte, which is the surfactant producing pneumocytes. And remember, after surfactant is produced, it's produced or stored in lamellar bodies. And then uh, 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 released when needed. So the type 2 pneumocytes produces this pulmonary surfactant, and then you've got your type 3 pneumocyte or the respiratory alveolar macrophages, if you will, that tend to eat and engulf the bad stuff that's not there. So it tends to fight off different things for you. When you get into your neonatal and pediatric, especially, and those of you that may have had kids before, you may have known that, if you're going to a full term pregnancy, hopefully that's in the ballpark of about 40 weeks. And if you're going to deliver preterm, so before 40 weeks, they would like the baby they would like for you to make it to 34, 35, or 36 weeks because it's been proven during that time of fetal development that the baby is actually producing what's considered to be mature surfactant. Mature surfactant means that that surfactant is being produced and readily available to help that baby be able to sustain extrauterine life. What that means is they'll be able to breathe because it'll be easier for them to breathe because they have the surfactant. Some, if they're born significantly before that, they don't have the pulmonary surfactant, so it makes it more difficult to breathe. And then there's also lack of the substance in there for the air liquid interface to occur. So you may hear of RDS, respiratory distress syndrome, that a baby can develop if they happen to have a lack of mature pulmonary surfactant. So they can actually do an amniocentesis, and they can do what's called an LS ratio. That's the ratio of lecithin to sphingomyelin. The easiest way I remember that is it's the opposite of what a normal IDE ratio is. So we know a normal IDE ratio, inspiratory to expiratory time ratio, is 1 to 2. The LS ratio is going to be the opposite of that in 2 to 1. Yes, Faith, what's the question?
Just to clarify, so pulmonary surfactant makes inflation easier by decreasing surface tension by does it directly reduce the radius of the alveoli, or does that happen?
So no, that the surfactant would make it easier to help increase the radius. So if we're going to fill that alveolus up, the radius is going to increase. Does that make sense?
Okay, radius increases to decrease surface tension.
Okay, I think the next slide will help out a little bit easier. So let me get to that, and then we can come back to this question if that's cool. That way it'll give a visual. Is that all right?
Yeah, okay.
All right, cool. So remember LS ratio 2 to 1. You also have to have the presence of PG for mature surfactant. When we talk about physiological significance of surfactant, it does reduce surface tension. So, all right. So what we're looking at here, Faith, and this, I'm going to try to answer your question with this. So when we look at the alveolus, this notice it says end expiration here and end inspiration here. So this is at the end of exhale. So I've blown all of my air out at end exhalation here. So at this point, the radius of this sphere is smallest. So as the per Laplace's law, as the radius of a sphere decreases, its surface tension increases. So here I have a pretty significant amount of uh, surface tension. So it's going to be difficult for this alveolus to inflate without the presence of surfactant. These little darkened images that we see here are the pulmonary surfactant that coats the inside of that alveolar wall. So with those being close in proximity, the surfactant molecules being close in proximity, it's actually going to reduce that surface tension. So although as the radius of the sphere is smallest and its surface tension will be highest, the presence of pulmonary surfactant reduces that surface tension to make it easier for that alveolus to inflate. So now we get to a point to where we've gone from end expiration, we've taken our breath in, the surfactant did its job, and it reduced the surface tension so that it would be easier to take the next breath in. So now that alveolus is nice and inflated. So yes, surfactant reduces surface tension, but it has to be uh, but it reduces surface tension when the alveolus is in its smallest form. When the alveolus gets a breath or if gets its volume and takes upon its shape, now we get into a situation where you notice that these surfactant molecules are spaced further apart. So there's a bigger gap between those surfactant molecules here than there is here. When that gap increases between the surfactant molecules, it becomes uh, more difficult for those alveoli, excuse me, more difficult for that surfactant to decrease surface tension. So when there becomes more space between the surfactant molecules, your surface tension actually begins to increase again. So it begins to increase again, and that's going to allow those elastic recoil forces to facilitate exhalation. So As so what we do here, because if you look at it says end expiration low surface tension, end inspiration high surface tension. That is in relationship to the role that surfactant plays with surface tension. If you remove if you remove the surfactant molecules away from this graphic, this radius of the sphere is much smaller than the radius of this sphere. So as the radius gets smaller per Laplace's law, surface tension is higher. So if you remove surfactant, then this is at end expiration, that's a high surface tension situation, as opposed to where that would be lower because the radius of that sphere is much larger. But when you take into account the role of pulmonary surfactant, as the radius of a sphere gets smaller, its surface tension goes up. But now we add in the substance that the body's produced, surfactant, that reduces our surface tension. It lowers the surface tension to make it easier to inflate that surface tension, to make it easier to inflate that alveolus. And then now, when the alveolar unit is inflated, those surfactant molecules on the inside have spread out. While they're spread out, they're not as effective at reducing surface tension. So surface tension actually increases at this point, and that facilitates the closure uh, during exhalation of that alveolar unit. So remember when we talk about those pressure gradients and pressure changes and so forth. Notice this is at end inspiration. So now we've got a situation where it's at end inspiration, mouth pressure or airway opening pressure is equivalent to our alveolar pressure. Now these surfactant molecules are spaced out, surface tension begins to increase. Remember, we said surface tension and elastic recoil forces are the majority of what facilitates passive exhalation. So now, as those surfactant molecules have spaced out, it increases the ability of that alveolar unit to now begin to go back to its smaller size. And as it goes back to its smaller size, yes, it does have high surface tension here, but as it goes back to its smaller size, those surfactant molecules get much closer together, so they're able to effectively reduce the surface tension, which is why you're seeing lower surface tension and higher surface tension here. Does that make sense?
Yes,
Sweet. So that did help Faith with your question then?
absolutely.
All right, very good. Excellent. Um, So then you look at the lung and the chest wall interaction. So we talked about the lungs have a natural tendency to want to recoil inward, while the chest has a natural tendency to want to move outward. So ultimately, you begin to look at the different phases that are occurring there. As if the chest is going to move outward, we know that's going to give rise to allow um, gas to begin to fill the chest, and then when you exhale, the chest is going to fall, and then you kind of see the vice versa uh, aspect of those items here with the lungs. So the lungs have the inward recoil, chest has the outward pull, and that's pretty much what you begin to see there. And we'll build upon this in the next time that we're together. But when you look at those lung thorax relationship or relaxation pressure curves, you can see how you've got the lungs and the thorax together, but independent of each other, how the chest wall itself moves versus how the lungs are going to move. And then it just kind of shows we started off with a tug of war picture. The chest wall or the thorax, the chest pulls in one direction, the lungs pull in another direction, and that pull helps to maintain balance, if you will, across the respiratory system. And I think that wraps us up for this time. What questions do you all have for me, if any? And if not, that we'll start the next presentation on next Tuesday, and then we'll we'll go over the test stuff. So does surfactant produce the air surface interface? No, surfactant does provide. So surface tension has the air surface interface, but surfactant does the air liquid interface. Does that help, Kayla? Very good. Well, I know we are a little early, but we also kind of skipped through the break as well. So, and I know you guys have another class here in just a little bit. So, unless you have any pressing questions or need for additional commentary, you guys are free to go to lunch and then get ready to get started at your other uh, get started for your other class when you're ready to go to that. Go to attend that. But otherwise, that's all I've got for the day today.
You said we're going to review when? I'm sorry.
Review for the exam on next Tuesday.
On next Tuesday. Okay.
Yep. So Kayla, you're asking for a mini understanding on PFTs. So what kind of specific question do you have on that? And I'm going to stop the recording right quick, and then we'll just because I will answer that shortly, but I'm going to stop the recording.